We invite anyone who has a question or a comment to come to the microphone, and we've got a few minutes before lunch.
Hi, thank you all for a comprehensive analysis of depression and SSRIs. I know we're left with like this conundrum of, is it the disease, is it the drug? And so I'm wondering if we should have a better biomarker for the disease. It seems like there's this tangle of drug effect, right? Like, I just don't feel like we have a good handle on the variability that you see with the drug effect. So do you all have any ideas? And likely obviously there's variability in the drug concentrations, but then, you also showed that the drug concentrations don't necessarily correlate with the effect of the drug. So is there a better pharmacodynamic marker for depression that we can individualize for patients? Because clearly there's a lot of variability, and I was just wondering what your thoughts are on trying to fine tune, the precision medicine aspect of this.
That's a tough one. Who wants to take that? Not me.
Yeah, it's a very good question, and I'll answer it in the following way, which may not be very satisfying. Because, it's interesting because I started as a physician. I was trained to think about teratology and certainly thalidomide, and then I became very interested in fetal alcohol exposure. And but over time, I think I've become aware of the importance of the clinical reality is that patients don't fit phenotypic boxes very well, and we have to think about keep a dimensional perspective rather than a categorical perspective. So at an epidemiologic and certainly at a clinical level, we all think about things that fit inside something that is a predefined diagnosis, but actually the reality is that the behavior is a spectrum. And as much as we want to make a diagnosis, we really have to think about everyday function. And probably one of the greatest challenges I think we have as scientists and practitioners is to figure out how to harness that perspective for both research and clinical care, which will move us away from thinking about depression as something like anemia. Or I often joke about having cardiology envy, because my cardiology colleagues can do an echo and then they can find out what the ejection fraction is, and then they can give a drug, and then they can reverse that or improve the ejection fraction. And we can't do that in behavioral developmental pediatrics. And I think that research-wise, that's equally true. So I'm not sure I'm giving you a very satisfying answer, but the reality is that we're going to have to find an answer in a different place, I think.
And I think, sorry.
Go ahead.
In pregnancy, it becomes even trickier because what's already such a broad phenotype becomes harder to assess, because if someone's always tired or if someone's having appetite changes, is it depression or is it the ups and downs of a normal pregnancy? So, yeah.
We should look at things more like, activities of daily living, quality of life. I mean, which is also subjective as well. But I mean, in the end, we're trying to improve health both of the mother and the baby. And I mean, should we be looking more at those types of endpoints as opposed to, a diagnosis of depression?
Absolutely. I think at the end of the day, it's about what does daily function look like.
Okay. But even in that context, I'm not sure that would convince a patient to change her dose. I mean, that's one of the problems that I saw. I mean, I see the same thing with hyperemesis gravidarum. Is like, there's such antipathy about not wanting to take a medication when there are, they've lost 5% of their body weight. And but they don't want to take a med. And that was my only way that we could, why did people change their doses? I mean, we could find no relationship to either their depression and anxiety scores, nor to their concentrations, and yet patients would go up and down on their dose, and it's like, what's the rationale? I mean, it's so hard to I mean, we're used to quantifying things. Somebody has high blood pressure, you give them a medication. If the dose isn't lasting, the full dosing, you increase it or you shorten the frequency. I mean, there's a prescribed way that we think about how we're supposed to dose things that are objective. And we're dealing in a realm now that we don't understand, and patients don't seem to necessarily do what we think they should be doing.
There's a couple of questions online. I'll try to summarize in really looking at confounding factors and beyond what you've looked at. Things like, have you looked at polypharmacy, chronic pain syndromes, and those things? And I found it personally very interesting that the number of patients you had who discontinued in the first cohort study you discussed, or about the number who discontinued antidepressants before pregnancy. And is there something that may differ between that population and the ones that continue through pregnancy and severity of disease or comorbidities? That would also play a difference. And then the other piece of that would be, did you look at the dose of the antidepressants that the patients were on as a covariate?
It's your studies.
Oh,
It was mostly the first and second.
yeah.
Not mine.
So that
You have another one.
That actually was equally interesting to us as well, and you wouldn't get that if you were looking at cohort level data. So that's where the power of big data is, and yes, there are a few jurisdictions where we can do that, like in Scandinavia and other parts of Canada, maybe even in the States. I'm not sure, but it does raise a really important question about what else is going on. And again, it goes back to this question of categorical diagnosis versus the dimensional perspective. The question is, what is in that dimension? And pain is clearly part of that. I would say that sleep is equally part of that. Exercise, family relations. I don't know how, somebody has to come up with some really novel composite score or a range of scores. And maybe part of the reason why phenotype and drug response is so elusive is because we actually probably don't have a good characterization of that phenotype. And because maybe there is a relationship there, it's just that we just don't know how biology and behavior are related. But which I think is the core part of your question, if I got it right.
I think so. And then going back to that correlation between concentration and phenotype, there was a question about, did you look at delayed changes in dose to phenotype, as it does take some time for the SSRI effect to full in?
Yeah, we tried. I mean, we looked back to see maybe it was lower at a certain point, or maybe there was nothing. I mean, we tried.
This question is for, pardon me, this question is for Catherine. Really enjoyed your talk, all the metabolism. So several of those metabolites are active too, right?
To certainly, yeah.
Yeah, did you take that into account in your data analysis?
So we didn't for, I mean, for both citalopram and sertraline, they're active, but the relative activity is totally different than fluoxetine. I did not present the fluoxetine data. I mean, I talked too long as it was. But with fluoxetine, clearly both the S and the R, as well as the S metabolite, are active, and we incorporated that. But because of the marked differences in activity, SSRI activity for sertraline and citalopram, we did not look at that.
Thanks.
One more real quick online. Did you evaluate adverse events of SSRIs in any of these studies, or more looking at the therapeutic effects?
You're asking me that one? We collected them, but it really, I mean, that wasn't, there weren't any. I mean, these were people, I mean, they weren't. I mean, these are people who were stable on it before they became pregnant. You know, the dose that they were on had been figured out so that adverse effects were not present. I mean, you collect that as part of the study, but there was nothing that stuck out at all.
Can I add just one thing?
Yep.
So we also didn't see dose effects in our Danish or our Canadian data set, which sort of comports with what you're saying. But one of the confounds even there is that if you're increasing your dose in the middle of pregnancy, probably your depression isn't super mild, right? So even there you have the piggybacking of increasing dose probably correlating with increased stress or depression symptoms. So it's not that clean.
I mean, that's what everybody has always thought, that the people who choose to stop their SSRI prior to conception are either people who are profoundly scared about drug exposure, or they're people who know that they can tolerate their depression so that it probably represents the mild to moderate, as opposed to those who know what it feels like when they go off their drug, that realize that the only way they're going to get through these next 9 months is if they continue their SSRI.
I think I'll also point out something, but I'll say this as a developmental pediatrician, not as a psychiatrist or adult psychiatrist. So that's by way of saying, take this with a cautionary note. I think we're talking about multiple forms, phenotypically maybe looking the same, but we're talking about multiple different disease entities. I think that many of the women in our birth cohort were already ill, symptomatic, long before they got pregnant. I think that's different than somebody who becomes symptomatic during pregnancy and then goes on an SSRI. So there's lifetime illness. There is differences between, and also differences with postpartum depression. And so we're probably lumping together multiple diseases or multiple clinical conditions.
Right, and in our study, these are all people who had major depression prior to pregnancy.
Yeah.
So there was nobody who, we did not enroll anybody who developed depression while they were pregnant.
Next question.
Thank you. Extremely thought-provoking, speeches, all of you. I have one small question. I'm Amparo de la Peña, Simulations Plus. Background is in PK/PD modeling, pharmacometrics, clinical pharmacology, hence the questions. When you showed the administration of the cocktail and the increase of concentration for the different drugs before and after, at what time were the postpartum samples taken?
They were all done distant. So they were done at the more than 14 weeks postpartum.
Okay, thank you. Because one of the things I was thinking that could be confounding that value is the change in volume, right, during
these were all
last
distant
trimester.
postpartum. Yeah.
Okay, and then the other question was with respect of, somebody mentioned having a clinical utility index of some sort. I think some of that data would be better analyzed using a more complex model, either a PK/PD model or a PBPK model that can take into account other factors. Mm-hmm. And then the third question or thought is for Dr. Oberlander's talk. I cannot imagine a situation in which a drug taken in pregnancy could still have a physiological effect 12 years later, unless there was a fundamental structural change provoked by the drug. I know that, of course, you have all the other external factors, psychological factors, raising types. Would there be a way that, we could have changed a genetic background or something more profoundly fundamental?
Yeah, a superb question. No, I don't believe, and I don't believe that the capacity for human development is that sensitive that an exposure in utero to manipulate a level of serotonin would have an enduring effect related to serotonin signaling. And I'm not saying that in relationship to alcohol or to any of the other behavioral teratogens that we know of. I think the point I think is worth taking away is, yes, there may be an SSRI, there may be a difference in children of mothers who were treated with an SSRI in pregnancy. And that is different than this is an SSRI-exposed child. And I think that the terminology has to shift. Because when we shift that focus, then we begin to think, well, what is it about the SSRI treatment in pregnancy that might tell us something about the risk for anxiety and depression in adolescence? And in that sense, we need to then focus on, was there a genetic propensity conferred on the child by the mother, who incidentally also needed to be treated with an SSRI, but because of the way in which we do these studies, we think, oh, we're going to find a difference in the SSRI group, as if it represents a change in brain function that had an enduring effect across adolescence. So I know this is a lot of words to qualify an answer to your question, which is a really, really core question. I think that at a evolutionary level, serotonin's been around for many, many millions of years, and it's been changing development in everything from, I think aplesia right up to us humans. It would be unlikely that shifting serotonin signaling within a relatively small range at a very critical period in development suddenly results in some hugely evolutionary change in human development that only occurs in the 20th and 21st century. That's not by way of saying that we know everything we need to know about changes in serotonin signaling in brain development, but I think we have to be very careful about what it means and defining that. And my sense now is that it, as I described, it represents a proxy of some other risk factors. And the question is, can we get at that, those proxies? Can we get at those other underlying factors that come with mothers, fathers, environment, and maybe what we're looking at is an enduring effect of that inheritance rather than the drug itself.
Although, I want to ask one question, and this is clearly coming from somebody who truly believes it's the genes that the kid gets are the same genes that the mom has, and whatever's, we're like our parents. And that the SSRI is, as well as the environment that we grow up in, are probably much bigger factors. But my one concern is when, and this is me speaking from a relatively ignorant position, but when I think about what has been hypothesized for the role of SERT, for that transporter on the maternal side, and that it's moving serotonin from maternal plasma into the developing fetus, and that's the sole source of serotonin early on. Can that affect it? I mean, is there a role for it? I mean, that's just something I would like to understand better.
Right. So there's some basic facts that we can't ignore. Sorry, I'm going to just carry this on one step further. There's some basic facts we can't ignore. First 5 weeks, we're very dependent on maternal source of serotonin. We don't have our transporter is not fully functional. No question about it. So what's happening during that period, and can we manipulate serotonin that has an enduring effect? Or is there a certain amount of redundancy, biologic redundancy built into the system, like SERT or these other transporters? Absolutely. And the other thing we probably can't ignore is that we are seeing something in utero, and I didn't show the fetal blood flow data we have, and the early infant data we have, and language data in the first year of life, which does point towards a serotonin signaling story. The question is that only related to SSRI? Is that related to the genes, SERT in particular? And why does that effect diminish over time, like all of the other things that happen in child development? Fortunately, child development is very robust, and we've endured for millions of years, and we will continue to do that. The real question is how do we support optimal outcomes? And I still think that at the end of the day, supporting maternal mental health in whatever way we can, pharmacologically, non-pharmacologically, has to be the number one goal.
Thank you.
All right. Well, we're a little bit over time, so I want to thank the panel for great presentations and response to the questions, and I think we're off to lunch. Thanks, everybody.